Okay, thanks, Bob, and hope you guys had a great day skiing. Just an FYI, and hopefully Bob doesn't start the clock, because these are two huge topics, and we're going to try to cover it in 15 minutes. So a couple of things. Number one, with the slide handouts, there's a lot more slides than we're going to be showing today, because we just can't do it in 15 minutes. Please look at those, and also some of you may have additional questions about your own practice, the use of PRP, the use of stem cells in your own practice, and honestly, I'm here for you guys. Pull me over at the end of this talk and we could talk more. And the last thing is, we'll have to talk a little bit quickly because a lot of ground to cover. So ready? Here we go. Disclosures, really nothing to do with the stem cell side of things. Why do we use stem cells in orthopedics in general? And there's no greater example than this early 1990s paper here from Europe, which ran a great experiment. And they said, well, we're going to harvest the cartilage, we're going to mince it up, and we're going to mix up that cartilage, and we're going to transplant it back into a cartilage defect. And then let's see what happens. And it's amazing what we've seen. And if you look at the black kind of winged structures there in the middle, those are tide mark cells that got displaced in the mix, and they think they're supposed to still produce a tide mark, but it's in the middle of the cartilage now. Obviously the tangential layer, that's all mixed up, and so the summary is adult chondrocytes know what they're supposed to do, and they maintain a certain amount of memory because they're mature. Stem cells are not, and we can tell them to be a tide mark, we can tell them to be a tangential layer, we can make them adhere to the underlying bone and the surrounding cartilage, so therefore there's a strong argument to use stem cells. And if you look also in the media, your patients are asking for it. Why? Because these guys are getting it. So if they get it, we should be able to get it. And that's creating quite a problem. And here you have these patients that are seeking these treatments from the sensationalized media, and then therefore the university centers are saying, you know, I'm not so sure we're quite there yet. But private clinics sometimes say, yeah, we're ready to go, and let's do it. And what's that happening is it's driving the system. And experimental treatments have been popularized and propagated by media, but we don't have a lot of sound science behind it. But the science is getting there, and that's what I want to talk about today. Well, here's a prime example that I think we've got to learn from, and we've got to know what can we do now in the clinic. And the FDA is pretty clear, and the FDA, just like the FDA, is pretty vague, right? And they say, sure, it is certainly your right as surgeons to use stem cells from that patient as long as you minimally manipulate them, whatever that means, right? And you do not combine them with anything except for water or something to store them in. And that's it. Anything else against FDA rules, and you better apply for an FDA license to use it. Well, along comes this clinic, and they say, hey, you know, we're doing the same thing. What I'm going to do is I'm going to take your stem cells out, and I'm going to put them in our lab. We're going to grow up a little bit more, and I'm going to give you your own stem cells back. I'm not doing anything else to them. And the FDA said, well, no, you're not, because that's manipulating cells, taking them out of the patient's body, putting them into a laboratory, and putting them back. So this is now a multi-year lawsuit in the National Appellate Courts, and the FDA won. Which says now that you can take stem cells from that patient and you can put them back, but you can't take them in the lab, obviously Genzyme and the whole special situations, but otherwise you can't take them out of that patient in the lab and put them back. And that's the new ruling. What's the ruling on putting them with the own patient's blood? How about the own patient's PRP? It's nebulous. And for the most part, I think you're going to be able to get away with it, and if you feel that's the right way to induce those stem cells, feel free to go for it. When you look at stem cells, they're everywhere in our body, and for good reason. They're remunerative cells. But when you're looking to use them clinically in orthopedics, you have only two options, and that is using ones from bone marrow, and we'll use those interchangeably with mesenchymal stem cells for a definition here, and adipose-derived, or using fat-derived cells. Bone marrow cells are readily available to all of us, and there are surgeons all over the United States and the world using them today. These are all of the the commercially available systems, there's probably more that I missed. And the only reason I highlighted the two on the top is because they come with a centrifugation system. Because as you're going to hear as a little theme through this is that you've got to get your cell numbers up. And maybe, just maybe, if you spin them down, when you aspirate from the bone marrow, you could get a higher concentration. So think about that as well. The good news about mesenchymal stem cells, they turn into anything you want. And that is definitely useful in medicine. The bad news about stem cells from bone marrow is there's not very many of them. And you can get a really big bone marrow aspirate, but you're still not going to get that many cells. And a lot of the literature shows, hey, we took these to the lab 3 to 5 weeks, and therefore we had enough cells. So be careful, and that is the strike against bone marrow cells. Keep in mind this one rule about stem cells. If you want to make a tissue, seek to get the stem cells within that same compartment. And it kind of makes sense in elementary, but in stem cell medicine, we didn't realize that till just a few years ago. And so bottom line is, if you want to make bone, get your stem cells from bone marrow. If you want to make fat, get it from fat. And this just shows clear evidence to suggest that bone marrow cells do better than fat. What about defect repair in animal models? And you look through the literature, and almost every study that you see that's well done shows a positive effect of stem cells. Again, very powerful in animal medicine. But if you look at the stem cells that are just injected into a joint without a matrix, the results fall off. Another trend to think about in the use of stem cells: give them a home, they work. You just inject them into a joint, they work less well. This is being used in sports medicine today around the globe. Here's a study showing ACI and bone marrow-derived stem cells. It's true the study showed no difference with the use of stem cells, but I included it because I just wanted you to know that this is usable and you can use that. You have all the tools to use it in modern-day practice. Clinical trials around the globe. These countries in yellow is where you can find a human trial, and if you want, you can send your patients there. The only one that is now closed to recruiting is Osiris, at least the only one that I know about. A fascinating trial, a fascinating company. But bottom line is, this is shrouded in secrecy, but the bottom line is, at least per their reports, their model is you have medial meniscectomy patients. We're not only going to make them feel better, we're going to regrow your medial meniscus. Wow. Now that's a big burden of proof. But hey, if they pull that off, this is going to be an incredible product. Keep your eyes open for Osiris. It's going to be the first thing to either not work out, and there's already been a lot of things that haven't worked out. Clinical trials, if you want to know where to send your patients around the globe because they're asking you, here's the list, okay? And it's also in your notes. If you want to send and you believe in it, just injecting stem cells in the joint, there's your countries. If you really prefer them to be on a matrix, stick to Egypt, Iran, Norway, and France is where you're going to find them. In summary, they're used all over the globe, and they're here. And as these next couple of years come by, we're going to see more and more use of these mesenchymal stem cells. What about the fat-derived stem cells? They're fascinating on their own right, and that's been a big part of my study within this field of stem cell medicine, is to try get these cells to do something. And whether it be cartilage or bone or fat, is really trying to get the recipe to make these cells do what you want. And if you ask, well, where did these cells come from? They were just discovered about 10 years ago. And now they're used all over the world for a very simple reason. They're easy to harvest, but most importantly, there's a lot of stem cells in fat. So therefore, you don't have to take it to the lab necessarily. And that, of course, according to FDA, is going to be pretty powerful things. And that's the reason to consider adipose-derived cells. You want to make fat, you should use fat-derived cells, but then what about cartilage? And yes, there's stem cells in cartilage, but there's not that many. And the jury's out on which of these two stem cell populations is best to use. And this slide here shows that the adipose-derived cells are better. Don't believe it. It's about 50-50 when you look at the literature, so there is no clear winner at this whatsoever. And feel free to use either one of them as far as your use in cartilage. This is part of our work of understanding how we could get fat stem cells. You can use liposuction aspirate. This is a study that's describing the use of arthroscopic harvest of these from the infratellar fat pad and some of the ways to do this and ways to avoid harm and to completely take out your fat pad, which is a no-no. And what you should know about this is that this is used all over the world, especially in veterinary medicine. And it's very powerful if you talk to the vets, and it's, again, all countries. It's divided into two same sections. It's defect repair, it's intra-articular injections, and the same rules apply. If you look at the animal models, all the way down, they're positive. It works. And it doesn't take many pictures, and I don't even have to label these pictures, because you could just see where the stem cells are added. You could see clearly that they produce the cartilage, so again, very powerful cells. This is quickly our system that is currently being worked on to really be used in humans. Stay tuned. I'll give you a quick preview on how this goes. This is changing MRI technology. We're creating special defects in cartilage. Again, here's a sagittal images. You can't see that this is a triangle, can you? So it's very difficult to appreciate volume. But then what we could do is we can dimensionalize then those MRI scans. We can tell the MRI to slice through the cartilage to get some volume defects size, as well as the surface. And we can teach the computer to say, let's find that ideal line in between that cartilage and bone. And then what we get is this ability to scan the articular surface and find what we want. That's the first step. You know, the second step is, well, then it's unlimited, right? Then we can turn this into engineering CAD drawings, as all our architects and engineers use. We can tell the computer, hey, fill this thing up and tell me exactly how much volume I need to prepare before the surgery. Tell me the exact shape, and I'm going to be ready for it. You can do preoperative molds now, and this is now pretty routine. Thermograde sterilizable plastic, and you can inject the stem cells and pop out your exact shape, whatever you'd like to do. Interesting, and it's, again, sorry I'm going so fast, but it's just the way that we're going to have to get through most of this. The media is interesting on what it takes to make these stem cells go into cartilage. The bad news is the FDA won't allow you to give any of those. But here's the interesting thing. Look at PRP. It's got exactly the same things we use in the laboratory, but it's got a little too much garbage on the end, right? And that's because of this big gamish, and one of the reasons that we're going to talk about in a few minutes why it doesn't work so well. But bottom line is it has a lot of things that work, a lot of things that don't work. We've got to start getting rid of the bad things, and so antibody exclusion of those types of growth factors, and then we have the same recipe, and then our results tend to get better when we use these cells. So interesting. Again, stem cells are powerful. The change of morphology is clearly evident. The way that they heal defects in cartilage in rabbits in all animal models is pretty fantastic. Therapeutic use in animals, again, we have from all over the globe. They harvest the same way in horses. Here's a horse, a racehorse, harvesting fat and injecting. But look at these results. These are racehorses, ladies and gentlemen, who are too lame to run a race. And if you give them an injection of these stem cells, this is tendinopathy, 77% of them get back to full speed racing as a racehorse. Pretty good model to use, I would say. Joint disease and osteochondral defects, 60% return. It's a 20% failure, but remember, they just injected these without a scaffold. Clinically used around the world, and human use is just around the corner. Give us another year and you're going to hear a lot more about it. Future directions, we just have to go quickly, and that is that there is 4 genes that you can give. This is called induced stem cells. We now have the technology to take our older cells and make them young again. I don't know if you've heard about this. This is fascinating technology, and all it takes is putting in 4 genes back into the cells to make them young. And so then we can tell them what to do, and then they go to their new home. This is the original paper if you want to get a little bit of idea of this technology. And certainly we would be remiss without mentioning, yes, you could take your own osteoarthritic aged chondrocytes and make them young again. So that's on its way as well as harvesting stem cells from peripheral blood. Okay. Sorry for that quick. Let's go to PRP. PRP has shown a lot of interest around the globe, and here's what's important in today's PRP world. PRP is not created equal, and you cannot use the same PRP for everything. You got to know what you're using, and you've got to document that on any research that you do, and you better hold the peer review if you're reviewing articles, and they'd say what kind of PRP to use because it's all over the map. Bottom line, this started with one of our early studies where we used the same patient's blood, 3 different companies and 3 different systems all at the same time. It should be the same. Not even close. Not even close, because some systems take away the white blood cells, some include the white blood cells and concentrate them. Oh wow, we got a big mixed bag here. And this is Lisa Fortier's article here that shows that with the white blood cells you get much more growth factors, at the same time much more inflammatory mediators. So be careful. And so we took this one step further and we injected these into rabbit tendons because there's no good animal model of tendinopathy. Right? So we used animals and normal tendons, and we injected white blood cell containing and non-white blood cell containing. Look at these results. This is interesting. If you include white blood cells in your PRP, you get acute inflammation. And when you do white blood cell less PRP, you don't, along with the controls. But here's even more interesting thing, and that is no matter what you do at 14 days in a rabbit, that's the chronic model, at 14 days, anything you do produced this sort of reparative response. So it may not matter that you're producing inflammation, but you have different mechanisms that this PRP is working on. And mostly, again, Lisa Fortier is suggesting you take some white blood cells out of your PRP, you have a better reparative response of collagen. It's the first paper of its kind. Evidence is starting to mount up for leukocyte-depressed PRP. All right, $1 million question, here it is, and I owe Steve Arnosky a lot of credit for this slide I stole off him, and really, this is it. There's over 6,000 articles, and if you read all 6,000, it's about 50-50. Yes, this works great, without a doubt, and this doesn't work at all. And what are we supposed to do, ladies and gentlemen, about this? I don't know, and so here's how to think about it. Number one, if you want to stack your bets because you want to use PRP, use it for lateral epicondylitis, because it's really the only thing that has really been shown to work better than other documented treatments. Stack it in your favor. Everything else, iffy. Here's iffy, but becoming more prominent, intra-articular injections to feel better after arthritis. Should we use it or not? Well, this is really interesting. These are all randomized controlled trials. And all of them that are pinkish show an effect that you improve the symptoms from arthritis if you give PRP. But notice one thing, and that is the yellow. And it's the only randomized controlled trial that used white blood cells within their PRP, and it didn't work. And that makes sense because that carries the inflammation, what we not necessarily want next to our cartilage. This is our upcoming studies that are coming out. It shows that this white blood cell containing PRP does injure the synoviocytes as well. Again, that's a more chronic inflammation type of model. So if you're going to use PRP in the joint, do not use white blood cell containing. There's now enough evidence to suggest that to the general orthopedic population. Be careful with it. All right, randomized controlled trial using patellar tendinopathy. We're near publication of this. I'll give you the short summary. PRP had a better effect with patellar tendinopathy, again, ultrasound-guided injections versus dry needling alone. Stay tuned. It's not published yet. It's not finished yet. Sneak preview, but it may work for that as well. And last thing about PRP. PRP today will not be the PRP of tomorrow. It doesn't work well enough, and we tweak it a little bit, it might. So these are all the current ways of manipulating PRP to get a better effect. We talked about one during the fat stem cells, right, about taking away some of the bad growth factors. Another approach is the isolation method, where big macromolecules found within PRP can be harvested, which are anti-inflammatory, etc. So that's another mechanism. And then the third is the combination mechanism. You inject this for lateral epicondylitis, and it's great because you get a reparative chemical response, but there's not enough cells to do anything about it. And so then if we add more cells with the PRP, we may get a better response. Eyes open for that. That's another new approach that's coming out. And lastly, this has created quite a stir in the PRP world. This is our article that just came out about the systemic effects of PRP. When you really study this and control it, it's true that the levels of IGF-1, VEGF, and beta-FGF, all banned by WADA, are significantly increased when you give a localized injection of PRP. Don't worry, it's not coming off the shelves anytime soon. It's not going to be banned in athletes, but we're working with WADA now to get the testing right, so we can tell the difference between PRP injections versus the doping that occurs downstream, right? Because human growth hormone makes insulin growth factor 1, and so we got to be careful because some of our PRP athletes are going to test positive currently, and so we're working with them to make those changes. Sorry for the whirlwind view, but thank you very much. And like I said, if there's any questions on either of these two topics, grab me afterwards. Happy to talk to you about more.